I think one of the things I'm hoping that'll come out of this new vaccine is renewed research and interest in novel ways of enhancing the efficacy, effectiveness and coverage of adult vaccines. And I'm going to say a little bit more about what we want to do on this campus, I think, about adult immunisation at the end of the talk. So let me just go. So, very nasty disease. I've only become aware recently that, in fact, you can not only get ophthalmic zoster, but you can get recurrent ophthalmic zoster with recurrent ocular symptoms and blindness, which I think is a new syndrome recognised and published by a group of doctors from Florida. So we're still learning about this disease, and we're still learning about its effect on stroke and myocardial infarction, all that sort of thing. And Christine showed this, that we see really a rise in post-herpetic neuralgia over the age of 50, but in our studies it was really over the age of 70 that the most feared complication of post-herpetic neuralgia occurred, and you can see this progressive rise in immunocompetent patients of the incidence of herpes zoster in Australia, which rivals most of the OECD countries when you compare them. And that correlates with a decline in T-cell immunity, but not antibody to varicella throughout life, particularly over the age of 50. And in fact, when Alison Abendroth came back to Australia, we rallied all of the neuropathologists of Australia and looked at a few cases. There are only 7 cases in the literature on the pathology of herpes zoster in neurons, because it reactivates in the dorsal root ganglionic neurons around near the spine, and we're actually able to look at the cells that were present, and they were CD4 and CD8 T cells. So it's not only what happens in the blood, it's what actually happens in the nerve that's important as well. And as Christine mentioned, Myron Levin and Mike Oxman, I remember sitting on Mike Oxman's couch as he described this trial to me, and I thought he'd have Buckley's of getting it up, and he did. 38,000 people immunised over the age of 60 in 10-year lots using a very concentrated live attenuated varicella vaccine called Zostavax, and as Christine mentioned, the efficacy being 51% against incident zoster, but this declined in people over the age of 70. You can see how zoster goes up in the placebo, but the protectiveness of the vaccine against incident zoster declines over the age of 70. And however, its efficacy, if we look at 60 to 69 versus 70 at over 70 years, the efficacy against post-herpetic neuralgia is retained, which suggests that the vaccine has an effect beyond its effect on incident zoster. It also decreases the severity of zoster in this older age group as well, so it has an attenuating effect, and that's going to be in quite contrast to what I'm going to show you with the newer vaccine. There were several studies of the duration of vaccine efficacy which were flawed, and I think probably the best data is that from Dr. Seng in LA, the Kaiser Permanente study showing that there is a decline in vaccine effectiveness out to about 7 to 8 years. Probably this is too broad, but here at 6 to 7 years we're looking at only 16% vaccine effectiveness. So this supports the case for a booster probably at 10 years. So the problem we have with Zostavax is moderate efficacy, which is lower in those over 70 and 80, and this declining effectiveness over 10 years. As Christine has mentioned, it's unsafe in the severely immune compromised. There's a lot of people with CLL, and with a wife as a hematologist, I keep asking her if there's any way in which one can discriminate between those patients with CLL with normal T-cell immunity and those without. And really there is no easy clinical way of doing that. So people with CLL, with chronic lymphatic leukemia, even though many of them are immunocompetent, really should not be given this vaccine, which is the recommendation. The safety in moderately immune-compromised patients needs much better definition. I've seen a couple of papers recently trying to look at that in patients on DMARDs, on these disease-modifying anti-rheumatic drugs. And we mentioned, Christine mentioned Zostavax, and the only, in terms of coverage, the claims from Seqirus are that they've distributed more than 50% of the doses in the cohort that they would expect to immunize between 70 and 79. Whatever the figures, even if they're lower than this, there are real implications for any new vaccine coming in, because we would then have to look at the prospect of boosting people who've had Zostavax in the past. And there will be a paper published in the next few months looking at the safety and immunogenicity of the new vaccine boosting of people who've had Zostavax 5 years previously. So the vaccine I'm going to talk about is the type of vaccine I've been involved in with GSK since they hauled me onto a board for herpes simplex vaccines in 1992, and that is using single proteins from the external surface of the virus, the glycoproteins, which fortuitously are not only able to induce antibody, they also induce T-cell immunity, and glycoprotein E is one of the best inducers of T-cell immunity to varicella. But if you purify away all the other proteins and only use a single one, you lose the immunostimulatory properties of the viral lipid and nucleic acid. So you need to replace this, and you need to replace it with adjuvants. With herpes simplex, we only used the MPL, which is a deacylated monophospholipid A, which means it's been detoxified as a component from the cell wall of Salmonella minnesota, and we only got a partial effect in herpes simplex vaccines. This vaccine uses DMPL plus QS21, which is from the bark of the South American tree, Quillargia saponaria. And the striking effect of this vaccine combination was shown in phase 1 and 2 trials, and you can see here we're looking at the immunogenicity, the T-cell immunogenicity of the vaccine with glycoprotein E alone, no adjuvants, in 50 to 59-year-olds, 60 to 69-year-olds, and over 70. And you can see this marked decline in immunogenicity with age. And we call this immunosenescence, and that's the problem that we have with the efficacy of all vaccines used in aging people, is this particularly this immunosenescence that affects all branches of the immune system, T-cell and innate immunity. But when the adjuvants were combined with glycoprotein E, and particularly the current dose, you can see there was no drop in the immunogenicity or the CD4 T-cell responses according to age, which was incredibly encouraging. I'll come back to that in a moment. So 2 trials were designed by Tom Heinemann and his colleagues, and I was a bit involved with this at the start, and that is that we wanted to look at people over the age of 50, but just simply recruiting people over the age of 50 would not actually give us sufficient power to look at those with PHN. So there were 2 concurrent trials, Zoe 50 in those over the age of 50, and Zoe 70 in those over the age of 70. So looking at efficacy against zoster, in both age groups, incident zoster and incidence against postherpetic neuralgia in pooled studies of those over the age of 70. And the results were of great interest, which I'll show you in just a minute. Randomized controlled trials run here and in Europe and the USA. It is a 2-dose vaccine, 2 months apart, 96% compliance, and I'll come back to that in just a moment, and in 10-year blocks. And the data I'm going to tell you is publicly available in 2 papers published in the New England Journal and an abstract on the immunology which I presented to the International Herpes Workshop about a year ago. The stunning results, which nobody expected and none of us could predict, were 97% efficacy, and there was no difference in terms of confidence intervals in Zoe 50 in the first trial between those aged 50 to 59, 60 to 69 and more than 70. And you can see how low our threshold for success might have been. So this was quite stunning. The first time we've ever seen a vaccine consisting of single protein and adjuvants outperform a highly concentrated live attenuated vaccine, almost unprecedented. And when Zoe 70 was looked at, the vaccine efficacy was 90%. Sounds as though it's different. In fact, if you look at the confidence intervals, they actually overlap. And it was similar in those 70 to 79 and greater than 80. The efficacy against postherpetic neuralgia was 89%, but there was no additional efficacy against PHN compared to the incident zoster. Unlike Zostavax, where we had this low effect against incident zoster in those over the age of 70 and retained efficacy against PHN, there was no difference. So the effect on PHN was due to the effect on preventing zoster. And there were no cases of PHN in those people under the age of 70 years. And this just shows the individual figures. 10 cases in Zoe 50 of breakthrough zoster compared to about 380 cases in the placebo group, and you can work out the number needed to vaccinate from that. And if we look at Zoe 70, 25 cases in breakthrough cases in those immunized for zoster versus about 280 cases in those who were in the placebo group. And the problem is there are so few cases, it really makes it quite difficult to analyze, because some of the studies we did immunologically were subsets, and there were so few cases it made it difficult to look at those subsets. And although we have some interesting anecdotal data, we're not going to be able to come up with a correlate of immunity, which is unfortunate, but perhaps good. And if we look at the data that we have over 4 years, you can see that there is again overlapping confidence intervals, so not really a marked drop in the efficacy over 4 years, and that is very encouraging, and I'll show you some more immunogenicity data in a moment. If we look at that just in terms of graphs, here's the incidence of zoster in placebo and vaccine recipients over a period of 4 years. It's really graphs what I showed you before, and this is with postherpetic neuralgia. So pretty stunning results. Now the downside of this is reactogenicity, and I'll just run through just the severe grade 3. You know that there are now differences in the way we're measuring severity of reactogenicity, and Merck have gone back and looked at their reactogenicity for Zostavax, because it's a selling point obviously, and they have now complied with the suggested standards of using 10 centimetres for local reactogenicity, whereas what I'm showing you here in terms of grade 3 is either systemic or local reactogenicity, which is sufficient to prevent normal daily activity. And this was greater in the vaccine recipients than placebos, and particularly the local reactogenicity, 9% approximately in the 2 studies compared to about 0.3% on average against placebos, but it really only lasts an average of 2 days. And I must say in my own patients, this has not been a major problem, although one has to consider you're only going to see 1 in 10. And 96% of all subjects received a second dose, and 91% of those with severe reactions returned for the second injection. There was no increased reactogenicity after the second dose, and in Japan a study was done of subcutaneous immunisation, and that's more reactogenic than intramuscular. Serious adverse effects were similar in placebo and recipient, and there were no increased autoimmune diseases or exacerbations observed. Polymyalgia rheumatica, of course, occurs most commonly in this age group, but we didn't see any exacerbations, although we need longer-term follow-up. Now, I'm only going to show you one of these rather complex graphs, which actually shows you the CD4 T-cell immunogenicity, and it's showing you the proportion of people who actually developed adequate CD4 T-cell responses above the threshold, and we looked at 4 different parameters of immunogenicity, 3 cytokines and CD40L, and you can see that the maximum CD4 T-cell responses occurred a month after the last dose and then declined, but actually plateaued, and they are a bit lower in those over the age of 70. One of the interesting things about this is that Maren Levin has analysed the Zostavax immunogenicity in comparison to this vaccine, and you get a 39-fold increase on average in the peak responses of CD4 T cells, whereas in Zostavax it's a 2-fold increase. So that probably tells us what the difference is. And you have to remember that Zostavax has 47 different proteins in it, only some of which are immunogenic, whereas glycoprotein E is highly immunogenic. So this may help us understand that. If you look at the average CD4 T cell response, it actually, you get the same sort of graphs. It's highest about a month after the second injection. And the phase 1 studies have now been extended to 6 months, and there appears to be a plateauing above threshold, and in the 70-year-olds there's really overlapping confidence intervals or error bars with the overall group. And if you take that out to 9 years, which has not been published, but I'm allowed to show it, you can see that is also continuing to plateau. So optimism for a longer duration of efficacy, but obviously what we need to do are the clinical studies, and that's what we're doing at present. So we're continuing to follow these people up for out to 9 years. There are some remaining immunologic questions. To me, obviously, these are most fascinating, and that is how long the humoral and T-cell response are going to remain, and the humoral responses also, of course, show a boost after zoster immunisation, but then they actually plateau as well. The relative importance, the mechanisms are, I think, what fascinates Maren Levin and I, and that is how can we do even better? How can we actually tackle these 10% of people who are not responding. So the relative importance of T cells versus antibodies, and we'll be showing that in our forthcoming paper, and that has some interesting aspects to it. The role and importance of polyfunctional CD4 T cells, which have been shown to be important in other vaccines. Is there a CD8 T cell response? A little bit of controversy here, but we find that CD4s and CD8s are present in the dorsal root ganglion after zoster. So as in simplex, we think CD4s and CD8s are essential to synergize with each other. And remembering, of course, that this condition, zoster, is a reactivation. It's not what we're doing here is immunizing people, not primarily, we're not priming them, we're actually giving them a boost to their memory T cell responses. So it's quite a different immunologic situation to trying to prevent herpes simplex. And the role of innate immune responses is really important, as I'll show you in a moment, because of the adjuvants. So the immune correlates of protection are going to be difficult to define because of the few breakthrough cases. And I mentioned the difference in the responses between Zostavax and this subunit vaccine. And the interesting thing is whether these responses will be improved after subunit vaccine boosting of Zostavax, and as I mentioned, that paper will be coming out this year. So in immune-compromised patients, we only have phase 1-2 trials. The data will be available soon and then hopefully published within 6 months. There's an awful lot of hematologists who are waiting anxiously for those results and also for the licensure of the vaccine. So you all know that the incidence and severity of zoster is proportional to the degree of immunosuppression, particularly T-cell immunosuppression, that in hematopoietic stem cell transplantation, there's an incidence of zoster of 15 to 30% in the first year, and stage 4 Hodgkin's, I always saw when I was practicing clinically, was the major concern for herpes zoster amongst the hematologic malignancies. So phase 1-2 trials have been carried out of this vaccine in autologous stem cell transplant for Hodgkin's, AML and myeloma, and they get comparable immunogenicity in antibody and CD4 T cells and reactogenicity to immunocompetence, and that's maintained for a year. And I mentioned the phase 3 trial data will soon be submitted. With HIV, we've seen a complete revolution, of course, with the use of antiretroviral therapy. So although zoster is markedly diminished by antiretroviral therapy, there is still a 3 to 5-fold risk if the CD4 is less than 200. And the phase 1-2 trials in 3 different cohorts of differing CD4 counts again showed good immunogenicity maintained for the duration and no worsening of CD4 counts, and it was safe, which I find fascinating. We need to remember that many questions I'm often asked, immunocompromise, autoimmunity, and adjuvant effects may all have different immunologic mechanisms, and we need more research into that to understand it. We need to compare Zostavax and this vaccine in mildly immune-compromised patients, particularly with respect to safety, and remembering that people always get concerned about adjuvants having an effect on autoimmunity, and that's why I made that comment a moment ago. So the issues are the 2 doses. What's the likely compliance in the real world? Will this high reactogenicity reduce uptake? The duration of efficacy is yet to be determined. I mentioned the booster issues and the risk of autoimmunity I've also mentioned, and the immune compromised, and I won't go on with that. So there are other trials still in progress, co-administration with other adult vaccines, which was an issue with Zostavax at one stage, immunization of previous Zostavax recipients, and safety and immunogenicity in other immune-compromising conditions, which are of intense interest to adult physicians in that area. Now, I think there are 3 major implications for this vaccine. vaccines consisting of a single pathogen protein and adjuvants can be efficacious, and more so than a live attenuated vaccine. Such a combination may cut through immunosenescence and provides hope for other vaccines in older subjects and also for the herpes simplex vaccine. And it is really important to do what Nathalie Garçon pioneered at GSK, and that is look further into adjuvant immunology. There are, of course, a number of other vaccines or candidate vaccines that do use single proteins in these adjuvant combinations. And my colleague Arnaud Didier-Laurent in Belgium has looked with Nathalie at the immunology of the adjuvants after intramuscular injection into mice, and shown that the QS21 component rapidly moves to lymph node and undergoes a very complex series of interactions with different cytokines through macrophages, NK cells and dendritic cells, ultimately resulting in CD4 T cells being stimulated, antibodies, and possibly also CD8 T cells. And tomorrow Kerry Sandgren starts work in our place to have a look at this in humans in collaboration with Arnaud. And I try and relate this back to our own work with Naomi Trong in the audience, and that is we've been struck by the complexity of the innate immune mechanisms after primary infection with herpes simplex virus, almost certainly the same with varicella, and that is one gets multiple dendritic cells involved, and probably all of the innate immune cells involved in the mucosa interact in ways to prevent viral infection or restrict viral infection. And so the linkage between understanding innate immunity to viral infections and the effects of adjuvants is going to be a fascinating match, I think, in the future. And finally, I just want to say what I think we're developing into a wonderful collaboration between, as usual on this campus, between hub partners, and particularly between adult and pediatric areas, and that is to try and create a completely translational Centre for Adult Immunisation with our group looking at adjuvant immunology and pathogen immunology, and Rob Boy and Richard Lindley looking at effects of shingles vaccines on prevention of hospital and nursing home admission, funded by a perpetual grant. And we would like to fill in some of the other areas here, talking to Nick Woods and Christine and others. And those are some of the gaps that we would like to fill in the future. Our group has met, and that group consists of some sponsors across the trial precinct, myself, Rob Boy, Christine and Peter, and a number of other people here who have committed themselves to being interested in this approach. So we hope that in the future we'll move along from private philanthropy and other grants to Sydney Health Partners, and maybe down here as well. So very exciting. And my colleagues who've been involved in all these studies, Himala Lal in particular, Lydia Ostvergels, Myron Levin, with whom I've worked closely, and Tom Heinemann, with whom I've also worked closely. And both Himal and Tom have moved to other vaccine companies. Thank you.